Welcome back to the Deep Dive. This deep dive is adapted from a clinician-written article published on Mentalyc, and we're bringing it to life in audio for those of you who prefer listening on the go, maybe between sessions or during your own admin block.
And we are really honored to feature the expertise of the author here, Gargi Singh. She's a counseling psychologist specializing in children and young adults. Her work offers these really deep, practical frameworks for turning complex depressive presentations into manageable, measurable treatment plans.
Yeah, and since this deep dive is based on a Mentalyc resource, it's probably helpful to know they're a clinical intelligence platform. They're designed to support therapists specifically with documentation, compliance, and, streamlined treatment planning.
Yeah,
It's all about using tech to save clinical time.
exactly. It's all about making sure that the administrative necessity doesn't compromise the clinical integrity of the work we do.
It really is. And let's start with a moment every single therapist knows. That feeling in the first few sessions with a new client. They're presenting with major depressive disorder, MDD, and you are just working so hard to build rapport, do a deep assessment.
Screening for risk, trauma history, substance use, all of it.
All of it. And then almost instantly, you have to translate all that nuanced human suffering into a compliant, billable, and yet still clinically meaningful treatment plan. You know the pressure. It's so hard to avoid just defaulting to those generic goals like improve mood or increase coping skills when the clock is ticking.
That tension is so real, and that rush often means the plan becomes this static piece of paper for the payer. It stops being a functional, evolving roadmap for the client.
So that's our mission today.
Right. We want to dive into the components that elevate a depression treatment plan beyond just mere compliance. We're focusing on how to achieve, radical individualization, ensure accurate measurement, and integrate those evidence-based approaches, CBT, IPT, ACT, in a way that genuinely serves the client's unique story.
Okay, so let's unpack that clinical tension. When we look at the source material, what did the article identify as the kind of non-negotiable foundations? What are the three pillars that hold up a truly effective depression treatment plan?
The article's core insight is that the best treatment plans have to be highly structured, so they give us clinical guidance, but they also have to remain flexible enough to evolve. And they must center on three critical pillars: individualization, collaboration, and measurement-based care, or MBC. If we just rely on a standard template, we miss all the clinical richness that only those three pillars can provide.
That structure is so vital. The source material lays out that formal flow we all know. You start with the overarching problem statement, which leads to the larger SMART goals. Then you break those down into concrete objectives.
Match with specific interventions.
And finally, validated by clear evaluation criteria. We know that flow is mandated by payers, but how do we make sure that mandatory structure stays useful, especially when we're trying to achieve that radical individualization you mentioned?
That's where we move from defining general goals to crafting really specific, observable objectives. The source gives us two great examples that highlight how context dictates the structure. Let's look at Michael. He presented with persistent depressive disorder, or dysthymia. His goal was to reduce his persistent low-grade symptoms.
Right, and his objectives were tied to tangible behaviors, which is, pretty standard practice.
Yeah.
The article points out objectives like reducing alcohol consumption, establishing a regular sleep schedule. But here's where it gets really interesting, clinically speaking. The intervention wasn't just general talk therapy.
Exactly. The intervention specifically used interpersonal therapy, or IPT, to address his strained relational issues. And those issues are often the underlying fuel for dysthymia.
Okay, so the insight isn't just that he needed therapy.
It's recognizing that dysthymia often manifests relationally, through unresolved grief, role disputes, social deficits, and IPT strategically targets that cycle of distress. It was a precise clinical choice tailored to his personality and symptoms, not some generic one-size-fits-all CBT module.
That makes the plan a powerful therapeutic tool, not just a piece of documentation. Now let's pivot and look at Emily. She's a 19-year-old college student with MDD, severe. Her severity and her context, being a student facing immediate crises, forced a completely different plan.
Absolutely. Her plan was all about immediate stabilization. Her objectives included developing a safety plan, attending therapy twice a week at first, and using specific campus academic support services. This really shows how the context, her environment, her level of risk dictated the frequency and the need for external resources to be woven right into the plan. That level of individualization is what ensures the plan evolves in real time with the clinical needs of the moment.
But let's be honest about the administrative reality this creates for us. I mean, this level of detail, making sure Michael's objectives are smart and Emily's stabilization goals are measurable and compliant, it's incredibly time-consuming. You're synthesizing diagnostic interviews, risk assessments, relational dynamics, and then you have to word everything perfectly. We've all felt that frustration of a plan getting denied because an objective was a bit too vague.
Or it lacked a hard measurement target.
Yeah.
It's the administrative hurdle that truly drains clinical time, especially when you have 5 clients waiting and you need to turn that plan around before the weekend. And that's why we need tools that work in parallel with our clinical judgment. The article points directly to the value of the AI treatment planner in overcoming this. It's designed to take your clinical assessment and your approach and generate plans that are automatically structured to satisfy payer requirements with the correct smart formatting.
So it's not replacing our clinical decisions about using IPT or safety planning, but it's handling the technical translation. The wording, the format, the compliance part.
Precisely. And crucially, it lets you track those goals and outcomes across sessions, which is the heart of measurement-based care. It transforms the plan from that static document into a living, evolving roadmap that you can actually use to guide your sessions.
Okay, let's deepen the context now beyond just structure and compliance and look at the article section on holistic care. It points out 2 key areas that are often rushed when clinicians are under documentation pressure, but which are absolutely fundamental to treating depression effectively.
We're talking first about trauma-informed care, TI. The source emphasizes that, given the high comorbidity, we have to assume that many clients with depression have experienced trauma. So incorporating elements of TI care into the foundation of the depression treatment plan, even if trauma isn't the primary focus right now, is essential.
Why is that non-negotiable, though? If we're treating depression, not necessarily PTSD.
Because trauma affects the nervous system and cognitive processes directly. If the client doesn't feel safe or if the interventions move too quickly, we risk re-traumatization, and that completely derails engagement. A trauma-informed depression plan might include objectives focused on psychoeducation about the nervous system or pacing strategies before we even touch the core beliefs about depression. It's about building a foundational sense of safety, which then maximizes the efficiency of any depression intervention that follows.
That shift in focus from just symptom reduction to creating a stable container first, that is a powerful clinical insight.
Absolutely. And the second key area here is strengthening measurement-based care, or MBC. While SMART goals ensure we have measurable objectives, MBC is the commitment to routinely using standardized assessment tools. The case studies mention using the PHQ-9, the Beck Depression Inventory, and for Emily, critically, the Columbia Suicide Severity Rating Scale, the CSSRS.
We all know those tools are important, but how does the regular structured use of MBC elevate the plan beyond just, simple scoring?
MBC provides the objective data to inform our decisions and demonstrate effectiveness to everyone, the client, the payer, and ourselves. Most importantly, it's the mechanism that tells us when the plan needs to change. If the PHQ-9 score isn't dropping, or if the CSSRS score increases, that data forces us to review our interventions and modify the roadmap. It moves us from subjective reporting into accountable data.
That creates accountability not just for the client, but for the fidelity of our own therapeutic approach.
It does. And speaking of long-term accountability, the source also highlights the need for a robust relapse prevention element in the plan. The goal isn't just to reduce symptoms and then stop when the PHQ-9 score is low.
Right. It's about creating a robust long-term strategy that identifies early warning signs, outlines self-management skills, and prepares the client for continuous healing once formal therapy winds down. This is where we shift from therapeutic dependence to client autonomy.
Exactly. A good relapse prevention plan is like a personalized manual for them. It explicitly lists their known triggers, their most effective self-soothing scripts, names their support network. It's arguably the most valuable outcome we can deliver to the client.
Quick pause here. If the administrative demand of building these detailed, individualized, and insurance-ready treatment plans incorporating TI principles and MBC criteria, if that feels familiar, Mentalyc can help. Its AI treatment planner supports your documentation process and clinical judgment while staying fully HAPA and SOC2 compliant. You can explore how it works for your practice at Mentalyc.com.
Okay, as we move toward our final thoughts on this, I want to offer one actionable step that any clinician can take today, when reviewing their current caseload.
Okay, lay that specific challenge on us.
When you review your client's active treatment plans, specifically check the evaluation criteria section and ask yourself honestly, does it rely on vague terms like client reports feeling better, Or does it truly use measurement-based care by listing a specific standardized tool and a target? For example, is it explicitly written as decrease in PHQ-9 score from 18 to 7 or less within 10 sessions? Focusing on this measurable objective ensures the plan is truly actionable and helps clearly identify when modification is necessary. It moves us beyond subjective reporting and into data-informed care.
That's such a critical point. If we're aiming for clinical excellence, our evaluation criteria has to be objective and evidence-based.
That level of measurable rigor is the difference between compliant paperwork and actual clinical intelligence.
So to summarize our deep dive today, the effectiveness of a depression treatment plan relies entirely on its deep individualization. Tailoring the approach like IPT for Michael or stabilization for Emily, and a real commitment to regular, objective evaluation. We need to remember those core pillars: individualization, collaboration, and measurement. But here's something for you to mull over. If the treatment plan is co-constructed with the client, if they sign off on every goal and objective, does the plan itself become a powerful early-stage therapeutic intervention? Does it promote agency and buy-in even before the formal work begins?
That's a powerful way to look at it. The act of planning is itself an act of collaboration, and it reframes the client as the expert in their own life. And if you're looking for a structured, compliant way to manage all those moving parts, those specific SMART goals, the evidence-based interventions, the measurement-based criteria Mentalyc's AI treatment planner can help you formalize those clinical steps efficiently. It really gives you back that precious time to focus on the human element of collaborative care.